I hope by now you've gone through both my talks on ECG key concepts and the talks on rate and access. Now we're getting a bit more to the juicy bit, thinking about looking at diagnosing pathology and serious pathology from an ECG. This talk focuses on looking for acute ischemic changes on an ECG. So hopefully by the time you get to the end of this teaching session, you'll be able to recognise and identify abnormalities found on an ECG that are associated with myocardial infarction. More specifically, we're going to look at ST elevation myocardial infarction, how the ECG can change over time when looking at these sort of acute ischemic events, and how we can localise ST elevations to particular anatomical regions. My chest pain talk goes over this in much more detail, but just a reminder at the start of this talk of ischemia on ECGs. An acute coronary syndrome refers to an acute supply and demand mismatch of oxygen to myocardial tissue. Angina refers to a syndrome where a patient would develop an ischemic type cardiac pain, but this pain would only occur on exertion. These patients can have changes on their ECG, but by definition, when we do their bloods, they are negative for cardiac enzymes, specifically troponin. A non-ST elevation myocardial infarction refers to a patient who has had an acute ischemic event, so ischemic chest pain at rest, and this is enough to cause a positive troponin result, so positive cardiac enzymes, but that we do not see ST elevation on the ECG. These patients can present with either a normal ECG or ECGs with some changes on them that could be associated with ischemia, but not ST elevation. A ST elevation myocardial infarction, by definition, presents with ST elevation in anatomically contiguous leads on an ECG. These patients will generally present with acute cardiac sounding chest pain at rest. They will have positive troponin results, but you don't need to wait for those troponin results to act on the ST elevation seen on the ECG, which itself indicates that they have a complete occlusion of the coronary artery associated with those anatomical regions. It is worth noting at this point the other type of myocardial infarction that we term a type 2 myocardial infarction. These are patients in which another pathology is present, such as a large gastrointestinal bleed. You may find that in this sort of patient, simply because they have huge blood loss or hemodynamically are unstable from another condition such as severe sepsis, will underperfuse their coronary arteries. This can, in extreme cases, result in ischemic type ECG changes. I've also seen it go to the extreme of having ST elevation on the ECG. However, the last thing that a patient with a large GI bleed needs is to be given treatment for an acute cardiac event, such as being given fondaparinux. They will just bleed more and you'll exacerbate their problem. So it's always worth thinking when you're seeing a patient whether there's something else going on that could actually be the primary root cause. So anything like this we would refer to as a type 2 MI. despite the fact that they can have positive troponin results and they can have positive ECGs. As I've just alluded to, a NSTEMI is a condition in which a patient will have cardiac chest pain at rest. They will have troponin which is positive when their bloods are drawn, and on their ECG you may see either some ST depressions and T-wave inversions that indicate that there is a degree of ischemia there, or a lot of these patients will actually present with a completely normal ECG. In contrast, a STEMI, by definition, will always have abnormal ECG changes. Specifically, there will be ST elevation in 2 or more anatomically contiguous leads. You then may also see ST depressions or T-wave inversions in other leads, which we term reciprocal changes. But there will always be ST elevation in 2 or more anatomically contiguous leads. These patients will have positive troponins when their bloods are drawn, but we don't need to draw their bloods. If they meet the criteria for ST elevation in 2 or more leads, they should be immediately referred for revascularization for primary PCI, well before anybody takes their bloods. A STEMI is admittedly a really horrible thing for the patient experiencing it, but for a doctor it's actually really quite a neat condition because you can tell an awful lot about what is going on within that patient simply by performing a non-invasive test in ECG. So from that patient's ECG, you can not only tell exactly where their occlusion is, but you can also tell how long that occlusion has been there for. So if somebody is having a STEMI, within the first minutes, what you will see on an ECG is hyperacute T waves. Now, normally as a doctor, you won't actually get to see these because if you're talking in the scale of minutes, usually these events occur in the community. The patient will have crushing central severe chest pain, and them or someone close to them will hopefully call an ambulance. By the time that ambulance arrives, those hyperacute T waves have probably already passed. So the only time you might come across this is if you're a junior doctor on the wards and a patient happens to have a STEMI as an inpatient and the nurse gets to them quickly and performs a ECG. If you can see hyperacute T waves on there, but there isn't any specific ST elevation, it's worth waiting for a short while and getting a repeat ECG just to check that that isn't the beginning of a STEMI. Then within minutes you start to develop ST elevation on an ECG. And as I described earlier, in other regions you may also start to see ST depressions. As things progress over the minutes to hours towards days mark, you will start to see some T-wave inversions. And once you're getting well into the hours of this event, you will start to see pathological Q waves. So this is where the first deflection within the QRS complex is negative, and it's a deep negative wave. These will usually start to occur once you're getting towards the 6 to 12 hour mark. So they're a sign that this isn't a super acute event, but something that has been there for at least several hours. And all of these changes, the T-wave inversions, the ST depressions, the Q waves, may then persist for days, weeks, and in some cases, years. So you may find that you're seeing people that have Q waves on their ECG which is an indication that probably at some point they've had a STEMI, but that may have been months or even years ago. Just a reminder, because I'll keep reminding you of this, but an ECG is a visual representation of the voltage of the heart as a function of time, as seen at various locations across the chest wall. So all we're doing is going around and taking a snapshot of the electrical activity seen from different locations in order to build up what is effectively a three-dimensional image of what's going on within the heart. So let's now talk some anatomy. For your purposes, start with the basics, which hopefully you have been across and learnt from phase 1. But I'd focus your attention on there being 4 main coronary arteries, or what we divide up into 4 main coronary arteries within the heart. So you have your left main stem. This then divides into a left anterior descending artery and a circumflex artery. Then there is also the right coronary artery. Of course, there are a multitude of branches that come off these arteries, which of course all have names. At my level, I start to worry about the names of those, but as I say, I think for 3rd year or medical school, if you can recall the location and what the arteries supply for the left anterior descending, the circumflex and the right coronary artery, that's close enough to what you need to cover your purposes. So your left main stem is your large trunk that then divides into your LAD and your circumflex. The LAD is probably, I would say, the most important coronary artery. So it's supplying the anterior wall of the left ventricle, so your main pumping ability of your left ventricle. It's also supplying your intraventricular septum and the apex. The circumflex, I always think of this to remember it as it's circumventing the heart. So it's wrapping around the heart, supplying the left atrium and the lateral wall of the left ventricle. The right coronary artery then supplies the right ventricle and right atrium. It then goes to the inferior surface of the heart, and usually, in roughly about 80% of people, supplies the posterior descending artery, which basically covers the posterior and inferior walls of the left ventricle. As I just alluded to, in roughly about 80% of people, the right coronary artery goes on to supply the posterior descending artery, and therefore the posterior and inferior walls of the left ventricle. We refer to this as a right dominant circulation. However, in about 10 to 20% of people, it is the circumflex artery which goes on to supply the posterior descending artery, and therefore the posterior and inferior walls of the left ventricle. There is also a certain proportion of people in which they have a co-dominant system, so both the right coronary artery and the circumflex are supplying the posterior descending artery. So now let's talk about where we see those anatomical regions on an ECG. We'll start by looking at the inferior leads. So remember back to the hexaxial system and where each lead of your ECG is reading. And hopefully it seems fairly intuitive that leads 2, AVF and 3 are reading in that direction towards the inferior border of the heart. So these are the 3 leads in which you would see changes, particularly ST elevation, that show that there is ischemia of that inferior wall of the heart. So this only works with a STEMI, so where you have ST elevation. An N-STEMI, you cannot locate to a particular anatomical region of the heart. But if you were to see ST elevation, it leads 2, 3 and AVF, or just 2 of those leads, that would be enough to meet criteria, you know that there is ischemia of the inferior wall of the heart. And we know from the anatomy we just discussed that in most people, that part of the heart will be supplied by the right coronary artery, although in 20% of people, or roughly 20%, that might be the circumflex artery. But usually it's the right. So simply by performing that ECG and seeing ST elevation in that region, we can be fairly confident that there is a complete occlusion of the right coronary artery. Now let's talk about our lateral leads on the ECG. Again, think back to your hexaxial system and your chest leads. So leads AVL and lead 1 read in that direction, which would cover the lateral border of the heart. And again, if you think about your chest leads, V5 and V6 are moving around to that lateral border of the heart. So if we see ST elevation in leads V5, V6, 1 and AVL, we would consider this to be a lateral area of ischemia, and that is usually supplied by the circumflex artery. Leads that are particularly good at looking at the anterior wall of the heart are your chest leads V3 and V4, and this area of the heart muscle is supplied by the left anterior descending artery. So ST elevation in V3 and V4, you're starting to think, is this a complete occlusion of the LAD? V1 and V2 are often referred to as the septal leads. So these leads are good at reading over the intraventricular septum, also supplied by the LAD. In reality, it's often more of a spectrum. So a large anterior STEMI could give it ST elevation from V2 all the way around to V5. And obviously where the occlusion is in the artery, so if it's high up, so proximal within the LAD, it's going to affect more territory than a distal lesion. And also we need to take into consideration that people do have anatomical differences. But for your purposes as a third year or just a medical student in general, try to think of those chest leads, sort of V2 to V5, as being the region where we would expect to see ST elevation in the context of a complete occlusion of the LAD. So now let's think about how we'd actually determine ST elevation on an ECG. In my previous talks on the sort of key concepts of ECG, we talk about the labelling of different segments and waveforms on an ECG. So the ST segment is the part between the end of the QRS complex and the beginning of the T wave. The TP segment is the region between the end of the T wave and the beginning of the next P wave. This TP segment is the least affected by any pathology, so we use this segment as our baseline. We can also define something as something called the J point. This is the junction between the QRS complex and the beginning of the ST segment. ST elevation is when the ST segment is elevated above the baseline, so that TP segment. Specifically, we look for the J point, which is that junction between the end of the QRS and the beginning of the ST segment, and look to see whether that is elevated in comparison to the baseline. In this example I've put together here, there's a very clear J point where the R wave ends and becomes horizontal, moving into a ST segment which is elevated above that TP segment, which is acting as the baseline. In reality, often it's not that clear. The J point is often diffuse or unclear. So what you're looking for in those particular cases is where that curve starts to become horizontal. So we define that as our J point. And then we're looking to see whether that point where it's starting to become horizontal is significantly raised in comparison to that baseline, the TP segment. ST elevations can have different morphologies, so they can be convex, so upwards curve of your ST elevation. People sometimes refer to this colloquially as tombstoning, because the morphology of that ST elevation, it starts to look rather like a tombstone, and also it is said that that may be the likely outcome of some of these STEMIs. There is also a concave upwards morphology of ST elevation. But ultimately, what we are looking for is that J point to see whether there is ST elevation above the baseline. Now, in a anterior or chest leads, we're looking for at least 2 millimeters of ST elevation above that baseline, whereas in our inferior leads, we would be looking for at least 1 millimeter. It's also very important to note that what we are looking for is ST elevation in contiguous limb leads or contiguous chest leads. So what we mean by that is areas which refer to the same coronary artery. So I don't think I've ever seen it happen, but if you saw ST elevation in V2 and ST elevation in AVF, those are from completely separate anatomical regions, and therefore that would not meet STEMI criteria. There would need to be an alternate explanation for what was going on there. But if you see ST elevation in, say, leads V2 and V3, which would be your anterior leads, or ST elevation in leads 2, AVF, and 3, which would be your inferior leads, those would be anatomically contiguous leads, so that would meet STEMI criteria. There are a few more complexities to STEMI criteria. If we're looking at a scenario where somebody already has a left bundle branch block. Also, at the moment, a new left bundle branch block in association with chest pain can be considered to meet STEMI criteria. But this brings another point forward, and that is you always need to consider the clinical context. It's unlikely that a patient will be accepted for primary PCI simply based on a ECG finding if they do not have the chest pain and the history that gives the clinical context to that ECG. So somebody who is pain-free, who happens to have ST elevation on an ECG, but that ECG has been performed for entirely different reasons, that is not really the same as someone who presents with central crushing acute onset chest pain. An ECG is performed and it shows ST elevation in contiguous limb leads or chest leads. Those patients with the history of the crushing chest pain of acute onset would be the ones that you want to be urgently referring for revascularization, so primary PCI. And like with anything, if you're in any doubt, ask a senior. This is particularly important in the context of a STEMI. A STEMI, by definition, tells us that a patient has a complete occlusion of their coronary artery, and that's why we need to revascularize them as soon as we possibly can. The window of revascularization is 12 hours, but the sooner we get blood flow back to that part of the heart, the more likely they are to be left with good heart function. Once that heart muscle has been without blood supply for getting up to 12 hours or longer, that heart muscle is likely to be damaged in a way that it will never recover from. Particularly pertinent in the scenario of a occlusion of the LAD, which supplies the left ventricle. If these patients aren't revascularized within hours, they will be left with severe left ventricular dysfunction. They may succumb to that STEMI, it may be the last thing that happens to them, or if they do survive it, they will certainly be left with severe heart failure afterwards. So it is really, really important that we identify these patients on their ECGs and get them to a centre where they can have their blood flow revascularized as soon as possible. So now let's look at some ECG examples. If you want to pause the video at this point and then you can go through this yourself and try and work out what's going on. It's a really great idea to get into the practice of going through an ECG systematically. So I've popped you 10 questions at the bottom here, which you can work through to try and identify the answers for this particular ECG. Always start by checking that you've got the correct ECG for the correct patient and what the clinical context of that ECG is. Then if we work through this one, we can see that there is a P wave present before every QRS and the rhythm looks very regular. So we would consider this to be in sinus rate. The rate itself, it's regular rhythm, so we can use the 300 rule. There's 3 big boxes between each R wave, 300 divided by 3, so this ECG is 100 beats per minute. If we then move on to looking at our axis, we can see that the waveforms are predominantly positive in leads 1, AVF and in lead 2, so this is a normal access ECG. If we then move on to looking for if there is any ST elevation, you can hopefully appreciate that in leads 2, 3 and AVF, the ST segment, specifically the J point, is elevated by 1 or 2 millimeters above that TP segment baseline. We can also see on this ECG that there is some ST depression and T-wave inversion in leads 1, AVL, V2 and V3. In leads 2, 3 and AVF, where we're seeing ST elevation, there is a downwards deflection, so a Q wave before the R wave. However, this is a very small downwards wave, so I wouldn't consider these waves to be a pathological Q wave. So I would say that there aren't any Q waves on this ECG. We know that leads 2, 3 and AVF cover that inferior portion of the heart, so this is an inferior ST elevation. And in most people, that inferior border is supplied by the right coronary artery. So this is likely a right coronary artery occlusion, but it is possible that it could be a circumflex occlusion. So I would summarise this ECG to call it an acute inferior STEMI with a likely right coronary artery culprit lesion, although this could be circumflex. Next ECG, again, at this point you could pause the video and work through the 10 questions regarding this ECG yourself. Check that you've got the right ECG for the right patient, and again, check the clinical context of this ECG. We then start by looking for P waves, and I can consistently see a P wave before every QRS complex. The ECG looks very regular, so we can already conclude that this is a normal sinus rhythm ECG. We then move on to looking at rate. Again, it's a regular rhythm, so we can use the 300 rule. There are 3 big boxes between each R wave, therefore 300 divided by 3 gives us 100 beats per minute. If we move on to looking at the axis of the ECG, the waveforms are predominantly positive in leads 1, leads AVF and lead 2, so this is a normal axis ECG. We then move on to looking for any ST elevation, and hopefully you can appreciate that there is ST elevation above the baseline of greater than 2 millimeters in leads V2, V3, V4 and V5. We then look to see if there are any Q waves. And hopefully you can appreciate that in the anterior chest leads, so V1, V2 and V3, before we move it, the first deflection within the QRS complex is a deep downwards deflection. So this would be a pathological Q wave. And what this is telling us is that that ST elevation has likely been there for several hours. We know that leads V1 through to V5 cover the anterior portion of the heart. So this is an anterior STEMI, and it is the left anterior descending artery that supplies this region. So this is likely a complete occlusion of the LAD. With a corresponding clinical context, I would summarise this ECG as a subacute anterior STEMI with a likely LAD culprit lesion. Again, pause the video now if you want to work through this ECG yourself first before we go through it together. Again, check that it's the right ECG for the right patient and the clinical context. Looking for P waves, there is consistently a P wave before every QRS complex, and the rhythm is nice and regular. So this is a sinus rhythm ECG. Moving on to rate, because it's regular, again we can use the 300 rule, and there are 6 big boxes between each R wave. 300 divided by 6 gives us a slightly slow 50 beats per minute. Moving on to access, we have a predominantly positive waveform in leads 1, but there are negative waveforms in lead AVF, but a positive waveform in lead 2. So we would consider this to be a normal access ECG. We then look for ST elevation. There isn't to me any hugely convincing ST elevation on this ECG, although you could consider that maybe there's a slight ST elevation in leads 3 and AVF. We're certainly seeing, however, some ST depression in leads V4, V5, V6, leads 1 and leads AVL. We then look for whether there are any pathological Q waves. So I hope you can appreciate that in both leads 3 and in lead AVF, the first deflection is a deep negative. So these are pathological Q waves. And these two leads, 2 and AVF, cover the inferior border of the heart. And therefore, we would think that in most cases it was the right coronary artery that was affected, although in roughly 20% of people, this could be the circumflex artery. As Q waves indicate that the injury has been there for some time, I would summarise this ECG as a possible old inferior myocardial infarction or STEMI of likely right coronary artery or possibly circumflex culprit. Another ECG, again, pause the video at this point if you want to and work through the ECG yourself. Again, start by checking your patient ID, date, time and the clinical context of the ECG. Moving on to P waves, there's a P wave present consistently before every QRS complex and it's a nice regular rhythm. So we can consider this to be a sinus rhythm ECG. Looking at the rate, as it's regular, again we can use the 300 rule. There are 4 big boxes between our R waves, therefore 300 divided by 4 gives us a rate of 75 beats per minute. Looking at the axis, the QRS complex in lead 1 is predominantly positive, but if we look at AVF, it is predominantly negative. So we move to look at lead 2, and again, the waveform is predominantly negative in this lead. So this is a left axis deviation. And so this would be potentially one of those scenarios where myocardial ischemia has led to a left axis deviation. We then look for ST elevation, and hopefully you can appreciate that there's quite a lot in this ECG. I can see ST elevation in V4, V5, V6, and also in leads 1, 2, 3, and AVF. There's no obvious reciprocal ST depression, but if we look at leads 2, 3, and AVF are inferior leads, the first deflection is a deep negative, so this is a pathological Q wave in these leads. If we then think about the region affected on this ECG, this is rather more widespread than we've seen in the examples before. So 2, 3 and AVF are our inferior leads, but we're also seeing ST elevation in leads, your chest leads, V4, V5 and V6, and also in lead 1. And these generally cover the lateral border of the heart. So in this example, it is both the lateral and the inferior walls of the heart that are being affected. So this is a scenario where we could probably conclude that this patient has a circumflex dominant arterial system. So their circumflex artery is supplying the inferior border of the heart. And they probably have an occlusion of the circumflex artery, which also supplies the lateral wall, so both the lateral and inferior borders of the heart are being affected. So I would summarise this ECG as a subacute inferior lateral STEMI with a likely circumflex culprit lesion in a circumflex dominant circulation. Final example in this talk, and this one is perhaps a little more tricky to analyse, and we haven't really talked over these issues, but it's worth being aware of. So if you want to pause the video at this point and have a look at the ECG yourself. So again, instead of freaking out that someone's placed an ECG in front of us, we're going to go through things in a nice calm logical order. So start by checking the ID, date and time and the clinical context of the ECG. Then start looking at the P waves. So here there is a P wave present before every QRS, and again, it's nice and regular, so we can use the 300 rule to calculate our rate. And there are 5 big boxes between each R wave. 300 divided by 5 gives us a rate of 60 beats per minute. We then move on to looking at the axis. We are predominantly positive in leads 1, in lead AVF and lead 2, so this is a normal access ECG. We then have a good look around the ECG for any ST elevation, and I can't see any in this ECG. However, when we move on to looking for ST depression, hopefully you can appreciate that there's quite marked sort of flat horizontal ST depression present in leads V2, V3, V4. You can also in these leads see tall R waves, and there's also upright T waves in these leads. This ECG represents a particular pattern which makes us suspicious that this patient might be having a posterior STEMI. So, what do we do next in this scenario? The usual 12 lead configuration doesn't look very well at the posterior wall of the heart. So if we see this configuration, we can think about doing a posterior ECG. All this really involves is taking off 3 of our chest lead poles and moving them round to the back of the body. So I would take off the stickers for V1, V2 and V3 and move those stickers and wires round to the back, so just carrying on further with your chest leads but curving round to the back of the patient. When you print your new ECG, it will initially write those 3 leads as V1 and V2 and V3. So it's important then to immediately mark them as V7, V8 and V9 to indicate that those are in different lead positions. You can now hopefully appreciate that there is ST elevation present in V7, V8 and V9. So this ECG confirms indeed this patient is having a posterior ST elevation MI. This would meet STEMI criteria, and therefore the patient could be referred immediately for primary percutaneous coronary intervention and revascularization of the artery. So that's it for now. So hopefully you now feel a bit more comfortable recognising and identifying abnormalities found on an ECG that are associated with acute myocardial infarction, particularly those of ST elevation.